So I hope you are saving your questions for the discussion or for break. But before break, we're going to have one last talk. So there you are. Shuvik, come on up.
Thank you, Lauren. Good morning, everyone. It's an absolute pleasure to be here. I'm Shovik Mitra. I'm an associate professor at UBC and a clinician scientist here at BC Children's Research Institute. So for all those who are here today, welcome to Vancouver, beautiful and bit rainy, which is unceded traditional and ancestral territories of the Coast Salish people, specifically the Musqueam, Squamish, and the Tsleil-Waututh nations. Now, I do not have any conflicts to disclose. The reason why I'm here with Impact is because of the fact that I try and do trials in the smallest and the sickest babies. So before we delve into discussion on implications specifically related to neonatal clinical trials, let's take a step back and look at life in a neonatal intensive care unit. For those who haven't been in this vastly different environment, as you walk in, you see a lot of clutter, a lot of equipment, a lot of very busy and skilled people who are trying to save the lives of these very vulnerable small sick babies. And then you have the parents, more visible in some units than others, depending on which unit you are in, scared, guilt-ridden. They haven't planned for this throughout their pregnancy, but now they are in the midst of the action. And in the middle of all of this walks in this enthusiastic research coordinator who wants to recruit these small vulnerable babies into the next big trial. So imagine how that would go. So with this background, I'm hoping that by the end of the talk, we'll be able to describe some of the unique challenges that we face in conducting clinical trials in the NICU, explain a bit of the concept of the pragmatic explanatory continuum as it relates to conducting clinical trials. And I'm hoping that all the experts here, and we have a lot of experts in clinical trials here today, which is great, you can propose some solutions to overcome some of the existing challenges, because I'm only going to pose questions. I do not have answers to any of these questions. And again, in 20 minutes, it is almost impossible to cover all aspects of issues around clinical trials. So the issues that I miss, I would love for you to bring those up and address that in our panel discussion. Now, before we delve into the details, I should take a moment to acknowledge the tremendous contribution that clinical trials have had in shaping neonatal care as we know today. And we cannot move on without acknowledging the contribution of Dr. Bill Silverman, who in the late 50s and 60s challenged the norm of eminence-based medicine, so to speak, in the ICUs, challenged his own biases on the use of steroids in retinopathy of prematurity, and conducted one of the first clinical trials to essentially prove himself wrong. And that would have been a highly humbling experience for the physician community in that era. Now, moving on, the culture of examining critical questions through randomized clinical trials really took off in the late 70s and 80s through trials on surfactant, PDA management, and so on and so forth. And here again, I would like to take a moment to acknowledge, and it makes me very proud, to kind of acknowledge the contribution of trials led by Canadian researchers on how we practice neonatal medicine today, be it trials on caffeine therapy, trials on indomethacin prophylaxis, trials on oxygen saturation targeting. And the one name that stands out in common across all these trials is Dr. Bob Schmidt, who we have the absolute privilege of having at this meeting 2 days from now. So if you're sticking around, do not miss that talk. But it was her and other researchers in that generation that kind of spurred the interest in the younger generation to try and examine more and more difficult questions in the NICU through randomized clinical trials. And that's why we see this increase in clinical trials over the course of the next 20, 30 years, where we examined a lot of difficult questions. But what we are left with right now is, have we become victims of our own success as we have pushed the boundaries of examining more and more difficult questions? And that kind of leads us to some of the issues that I'm going to highlight in today's talk. Is what are the challenges with contemporary neonatal clinical trials? And I've tried to organize those issues in the PCOT format so that we can kind of go back and discuss each of these issues in a more structured fashion. So starting off with the participants. As we push the boundaries of survival and the kind of babies that are thriving today, the participants in clinical trials are becoming more vulnerable than ever before. But have the clinical trial methodologies evolved to adequately incorporate these patients in contemporary clinical trials? Are they even truly represented in the trials that are intended to represent this population? Second, the interventions and the comparisons. Neonatal care is becoming increasingly complex, so are the trial interventions. Are the trial designs appropriate to examine these increasingly complex interventions? And when we talk about simple drug trials, again, we want to spend some time on that. Are we testing the right doses of these drugs in the right population? Second, and a topic very, very close to my heart, the outcomes. Are we looking at outcomes that are just easy to measure for us as researchers? Or are we looking at outcomes that are actually important to families and outcomes that align with the research question? And finally, something that we don't talk about often is the timing of outcome assessment. Does it really matter when we assess these outcomes, and how does it impact our decision making? And the overarching issue that underpins all of these facets is the issue of trial design. Are we paying enough attention to figure out whether the intervention is, like, we're designing a trial to explore if the intervention is meaningfully improving the health of an infant when appropriately used in a busy, high-intensity clinical setting? That is more of a pragmatic trial. Or is my trial intended to explore whether the intervention clearly changes the disease process in a specific patient phenotype when administered under strictly controlled conditions? So we would want to kind of spend some time discussing this paradigm and how it relates to contemporary clinical trials and where we kind of get ourselves in a mess. So starting off with the participants, as I said, that the reason why neonatal trials came up in the first place is because of the fact that, well, children are not just small adults and babies are not just small children. So we need to generate information in the specific neonatal population. But now we are pushing our boundaries. And we're pushing our boundaries further as our patients get smaller and smaller and more vulnerable. So the question is that now we have reached a point where, are we adequately examining these patients who are the highest risk of morbidity and mortality? Because preterm babies are not just small babies, and extremely preterm babies are not just smaller preterm babies. So I've kind of divided the issues around the challenges in incorporating this specific population in contemporary clinical trials into broadly two headings. One, issues around eligibility, and issues around informed consent. So when we look at eligibility, and when you read a lot of contemporary clinical trials, you see the list of exclusion criteria getting longer and longer and longer. And you wonder that, do you really need to exclude some of these patients just because they've been excluded in other trials? So for example, congenital heart diseases. congenital defects. Some of these patients have nothing to do with the intervention that is being tested. Yet, we just exclude them because it's easy to get through REB. And then we end up with no data on how that intervention interacts with these patients with these complex conditions. Something to think about. Next is dealing with our own biases. Far too often, we see babies not being included because we as physicians feel that, oh, that patient is too sick to participate in this trial. And further, sometimes we even feel that I'm convinced that this interventional control is going to harm this patient, and therefore I want to take this child out of the trial. Now, how do we deal with that? And finally, even if we are convinced about the equipoise, we struggle with a very limited time window in a lot of neonatal trials where we need to recruit babies within minutes, hours, or days after birth. And depending on the resources that you have, sometimes it's very difficult to approach parents and recruit babies in that time window. And that's why we miss out on a lot of these very sick babies in these critical neonatal trials. So we can talk about a lot of different ways how we can address this, and I would love to hear from the experts. But one thing that we can absolutely start off with is incorporating a trial culture in the neonatal unit, where we emphasize and re-emphasize the fact that we do not know what we are doing with these smallest and sickest babies in the first place. Well, the counter argument that I often get is that when you're doing a trial, you still don't know which one is better until you end the trial and analyze the results. But at the very least, by participating in a trial, you're reducing the variability. And if you look at the QI literature, even that has shown to improve clinical outcomes. So that's the counter argument. Now let's focus on informed consent. Now, as I said, that in the NICU, the parents are probably in their most emotionally vulnerable state ever. They have very limited cognitive bandwidth. Their cups are full. So that's the reason why we probably get the highest rate of consent refusals, because they cannot just take in anything more in the NICU. And I often wonder that even when we get consent in those very small time windows, how informed is it truly when they are so vulnerable in the NICU? So it is imperative that we start having an honest, true discussion about exploring other forms of consent, because otherwise we cannot move forward, especially with regards to generating evidence in the smallest and sickest babies. So people are already exploring other forms of consent. There's a large feeding trial going on in preterm infants. That's a multi-center trial that is exploring a two-stage consent pathway that includes a preliminary assent followed by a more formal informed consent. But in some cases where we are struggling with a very small time window, some people have looked at the possibility of an antenatal consent. Now, there are pros and cons depending on how you time your consent. In a trial that we are running right now that exclusively enrolls babies born less than 26 weeks of gestation, we have seen that it works slightly better because there is a sense of a bit of control before the baby is born, and therefore there's a bit more time to sit down and talk about the issues around trials. But as this publication from the support trial showed, that it comes at a cost. It comes at a cost of resource use and wasted resources, because a lot of the times, depending again on how you time it, a lot of these babies will not be eligible by the time they're born. So you need to keep that in mind if you're considering antenatal consent. But then there are some cases where you cannot predict when your baby will be eligible. Those resuscitation trials right after birth. And that's where it gets really tricky. Now, there's a lot of discussion and debate on deferred consent and waiver of consent and whether it is ethical. And there's arguments that you cannot do a trial without getting an informed consent. But I would like to pose a question to the audience here that is it not unethical to exclude these very sick patients from neonatal trials and just let them die because of lack of evidence, because we could not get informed consent? So I would really love to hear at the end from the panel on their thoughts on doing trials on these very, very small sick babies. Next, talking about trial interventions. Now, what kind of interventions are we testing in neonatal trials? Are these specific interventions or management approaches? And if we look at the larger trials that have been published in the last few years, you will find that we're exploring more and more of complex management interventions, such as blood transfusion strategies, PDA management strategies, platelet transfusion strategies, feeding strategies, which again brings back the question that are we trying to test the effectiveness of a particular intervention within that broad management strategy, or efficacy of that, or the effectiveness of the strategy itself? And that kind of directly relates to the kind of design and the outcomes that we choose. And when we talk about drugs, there are some specific considerations that we should kind of look at when we think about neonatal drug trials. Because again, in the entire lifespan, this is probably the most dynamic phase where the metabolism and clearance of drugs are changing based on gestation and postnatal age. But if we look at a lot of the contemporary trials, they have used empiric drug dosages. And there's a lot to learn from those trials. If you look at trials of prophylactic indomethacin, more than 19 trials that have been done, almost 4,000 babies enrolled. The most common doses that have been used is the ones that were tested in fetal lambs back in the 1970s. If you look at ibuprofen use in PDA management, the first trial, phase 1 trial that was done in Montreal in mid-1990s, used a dose of 10 milligram per kilogram as a starting dose, followed by 2 doses of 5 and 5 at 24 and 48 hours. 30 years later, the largest trial that was published this year in New England Journal of Medicine used the exact same dosage. So, food for thought. And more so with acetaminophen trials. 12 years back, colleagues in Israel were testing acetaminophen for a completely different indication at a dose of 15 per kilogram, and incidentally found that the PDAs were closing. That led to a slew of 22 randomized trials testing acetaminophen with all different PDA management strategies. And guess what? What didn't change? The empiric dosage. So kind of that raises the question that should we do better? Should every neonatal drug trial have an embedded neonatal pharmacology component? And we have world experts here with us today to kind of shed more light on that. So I'd love to hear from them as we move along in the panel discussion. Then talking about outcomes. Are we choosing the right outcomes? Now, we kind of, in neonatal care, take a lot of pride in promoting ourselves as proponents of family-centered care. But when it comes to choosing the outcomes, well, we haven't done a whole lot until recently, where we are starting to explore what's important to families when it comes to the health of their child. And that kind of leads us to a little bit of a controversial issue, because in recent times, I've listened to talks where there's a lot of trial bashing when trials have not included outcomes that have been highlighted by parents as most important. But I would argue that it depends on what kind of trial you're trying to do. If it's a pragmatic trial, then yes, the outcomes absolutely should directly relate to the the outcomes that have been highlighted by families as most important. But if it's an explanatory phase 1 trial, shouldn't the outcomes relate to the disease physiology that is in turn related to the outcomes that matter to families? So again, food for thought. That's where core outcome sets are important. So that's where the core outcome sets are important, and so is bringing in families in the discussion. I'll skip this, which is on trial reporting, which is equally important, where it's not only important what outcomes we select, but also how we report those outcomes. And these publications have shown that we're not doing a good job at that. And finally, the timing. We've seen a lot of trials where we find that the trials have shown a change in family important outcome short term, but in the longer term, there's no difference. So do we say that the intervention is ineffective, or there's a possibility of post-randomization confounding? And just to give a brief example, we do a trial intervention at time 0. We find some difference at the first time point, and then we have a bunch of co-interventions that are done over the course of time, and at 5 years, we find no difference. So do we say that the intervention didn't work, or we just ignore all the good work that our colleagues have done? So that's something that we need to consider, and what kind of co-interventions are allowed in trials, which brings us back to the pragmatic explanatory continuum. In summary, what I would like to highlight today is that neonatal trials are becoming increasingly complex, both in terms of the population and also in terms of the protocols. And therefore, it is imperative that we explore and encourage alternative consenting strategies. We should clearly define what we are doing and design the trials accordingly. And hopefully we can have some time in the panel discussion on the PRECI tool and how that could help in kind of deciding on the pragmatic explanatory approach. But regardless of what we do, I think it's imperative that we actively involve parents early on in the trial design process, so we have a shared understanding on the trial question, design, and the outcomes. Thank you.